Hello friends, today we'll see about the bronchoscopic management of a central airway obstruction caused by extrinsic compression by anaplastic thymic carcinoma. As you can see from the x-ray here, there's a huge thymic tumor which is causing a significant obstruction of the trachea and the patient is not even able to lie down. So in this case of emergency airway obstruction, an awake bronchoscopic intubation was done without the use of any sort of sedatives or paralytics. And once the bronchoscope is passed, now you can see there is a presence of a significant narrowing of the mid-trachea caused by an intrinsic growth along with compression from the outside. This has resulted in an imminent airway obstruction, and below the site of the critical obstruction as well, there is a compression of the carina along with the left main bronchus. So this is a very critical site of obstruction which is preventing the patient from even lying down. So a decision for an awake fiber optic bronchoscope is done without the need for any sedation. The bronchoscope is passed preloaded with a microlaryngeal tube, and the scope is negotiated through the site of the airway obstruction, and the tube is passed beyond the site of the airway obstruction, and the airway is then secured. Once the position of the tube is confirmed beyond the site of the obstruction, sedative and paralysis is given and the patient is put on mechanical ventilation. Now, once the patient is able to lie down with the help of mechanical ventilation, venovenous ECMO is initiated through bilateral femoral vein. The guide wire is passed and then the dilator is placed and then the cannula is inserted, and you can see the gush of the blood coming through the cannula, which is then going into the membrane oxygenator, and then the oxygenated blood is coming back through the cannula into the femoral vein. So this was a case of a VAV ECMO which is initiated as a bridge to the stenting, and once the ECMO is initiated, now the patient is then once the patient is stabilized with the ECMO, now rigid bronchoscopic intubation is being done safely. This ECMO helps us to avoid the desaturation as well as lack of ventilation during the time of procedure. Now a cryoprobe is passed through the bronchoscope and the initial tumor fragments which is causing an intrinsic obstruction of the trachea is removed with the help of the cryo extraction with 1.1 millimeter cryoprobe. And once it is done, now we are passing the bronchoscope and you can see there is still an element of a significant airway stenosis despite cryo extraction of the tumor segment. So now we need to plan an self-expanding metallic stenting to overcome this site of since both carina as well as the left main bronchus are critically involved, a decision for a self-expanding metallic Y stent is being made. Under a C-arm guidance, the guide wire is passed over that the stent deployer is railroaded, and the self-expanding metallic Y stent is being gradually deployed under the C-arm guidance as well as a direct visualization with the help of a bronchoscope. And once the self-expanding metallic Y stent is put in place, now you can see that the stenosis at the end of the carina as well as the left main bronchus is completely relieved. However, we continue to have a tracheal stenosis above the level of the self-expanding metallic Y stent. To overcome the residual airway obstruction, a decision of a straight self-expanding metallic stent is being made, and the straight self-expanding metallic stent is introduced through the rigid bronchoscope under C-arm guidance, and gradually it is then inserted into the already existing self-expanding metallic Y stent. And as you can see from here, this has to be done meticulously to get the perfect precision of the deployment of the straight self-expanding metallic stent. And once it is done, now you can see that there is a complete recanalization of the airway, and we have given enough margin above the level of the critical airway obstruction to prevent the stent migration, and a stent in stent is placed with a self-expanding metallic Y stent below and a straight self-expanding metallic stent above. So once it is done, now you can see that the airway is almost completely recanalized, and the patient was then extubated on table. Later, after around 2 hours, the patient was relieved from ECMO and the patient was able to vocalize, and the next day the patient was able to walk around, and then the patient was discharged in a stable state for further palliative care. This is a very successful case of a difficult stent in stent insertion being done for a patient with ECMO being the bridge to the stenting. Thank you.